Firstly, can I introduce myself? My name is Stuart Malcher. I'm the Acting Executive Director of Family and Community Services, Insights Analysis and Research, but better known as FACSIAR. Before we begin, I'd like to acknowledge that wherever we're joining today's webinar from across New South Wales, that we're all living and working on Aboriginal land. And I would personally like to acknowledge the First Nations people of the Earlwood area, where I have the privilege of joining from today, and that being the Bedjigal people. I would like to acknowledge and pay my respects to all First Nations elders, past and present, and to future and emerging leaders. And I'd also like to extend that respect to our Aboriginal colleagues joining us today. With that, again, a warm welcome to all our webinar participants today that we have with us, but in particular, we're very fortunate to be joined by our presenter, Professor Melissa Green. But I would also especially like to welcome all our colleagues working directly with clients in frontline service delivery from across the many DCJ districts or one of our not-for-profit partners. So today, we're very pleased to be showcasing the work of the New South Wales Child Development Study. The New South Wales Child Development Study is conducted by the University of New South Wales in collaboration with a number of other universities and in partnership with a number of government agencies, including the Department of Communities and Justice. It is a significant longitudinal population study on the mental health and wellbeing of a cohort of 91,635 children born in New South Wales between 2002 and 2005. And this study links administrative records from multiple New South Wales agencies, including our child protection and out-of-home care data, as well as data from health, education, and from justice. Now, in FACSIAR, we've been very long-standing collaborators with the New South Wales Child Development Study and really seek to champion its findings to help inform our policy and practice. And in this webinar, we are very fortunate to be joined by the study lead, Professor Melissa Green, who will present a range of findings from the second wave of the study in relation to children who have come into contact with the child protection system. So if I can, without embarrassing her, give a bit of background on our presenter. Melissa Green is professor at the University of New South Wales in the discipline of psychiatry and mental health, and she is also group leader in stress-related psychopathology at Neuroscience Research Australia, where her research aims to understand the interaction between social and biological determinants of mental disorders from a developmental life course perspective. And as I've already mentioned, she is the lead of the New South Wales Child Development Study. Now, just after the presentation, I will lead a Q&A session with Melissa. So please, any questions you have, can you pop them in the chat throughout the presentation, and we'll come to those at the end. Also want to let everyone know that today's session is being recorded and will be posted on our FACSIAR webpage. And anyone who's RSVP'd for the webinar will receive a link to that recording in a couple of days. But I'd also please encourage everyone to have a look at the FACSIAR webinar page, where you'll find the 8 FACSIAR evidence to action notes that can provide you with plain English summaries of the study findings, as well as some infographics that you may want to use in your work or presentations. So with that in mind, let's get started. And I'm very pleased to hand over to Professor Melissa Green. Thanks very much.
Thanks very much, Stuart, and also a special thanks to Grace and Caroline for their organisation of this session, and thanks for inviting me. As it's been mentioned, I'm going to be presenting on findings from the New South Wales Child Development Study, and in particular focusing on things that have emerged from our second wave of record linkage. Before I start, I also would like to acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional custodians of the lands that we're meeting on today, and I am myself situated today in the lands of the Gundungurra people out in the Blue Mountains. I pay respects to elders past, present and emerging. I also wanted to begin by acknowledging the many data custodians that contribute to this study. I'm not going to read them all out there, but did want to clarify that any information and views reported here about these data don't necessarily reflect the views held by the departments that contribute those data. So with that, I'll start with an introduction to the study for those who are not familiar with it. The Child Development Study is a statewide population cohort study, and it uses repeated waves of record linkage to follow a school-based cohort of children in New South Wales. They started school in 2009 and were assessed on the Australian Early Development Census. So the image that you're looking at there shows a timeline, and in the middle you can see 2009 as the point where the study kind of started. But record linkage 1 was a retrospective linkage back from the child's school age back to their birth date, and for the parent data it went back even further to 1994. So in that early wave we had information from all departments and focused on the early childhood development census as the focal outcome for wave 1. But when we then conducted the second wave of linkage that you can see there was undertaken in 2016, that incorporated a second cross-sectional assessment for the children that we initiated as researchers, which was designed to provide an opportunity for the children to self-report their own mental health and wellbeing status. And that was conducted when the children were in year 6 in primary school. And there'll be more detail about the machinations of how that happened as the talk progresses. But that assessment was able to capture around 30% of the original sample, and the linkages continue on for the entire sample, those that were assessed with the AEDC and or the Middle Childhood Survey. So together that's 91,635 children that's represented at the bottom of this slide. The other thing to say is that we are currently analysing the data from the third wave of linkage, which was conducted last year. And so this is a quite exciting time for us in this study where the children have finally reached adolescence. They'll be at a point in time where for us as mental health researchers, they really will start to show the emergence of some crystallised mental health problems that we will then hope to be able to understand how those have come about over the life course, having this wealth of data from the child's birth and prior in the case of their parents. So what I'm going to start by discussing with you is actually 2 studies that were undertaken with that early childhood or early development census that was administered to the children at age 5 years. So the first paper was actually conducted with our wave 1 linkage data. And the reason I'm starting with this is because these papers really set the scene for the importance of the child protection notifications in very early life, so before school entry, as being a red flag for the emergence of other developmental problems and later mental health issues. So even though the work wasn't focused on children known to DCJ, I did want to run you through these initial papers that set that scene. So this work used the AEDC teacher ratings on the 16 subdomains of the AEDC. These 16 subdomains underpin the 5 core domains that you're probably used to hearing about: the social competence, emotional maturity, physical health and well-being, language and cognitive skills, and communication domains. So underneath those 5 domains lie these 16 subdomains. And we wanted to use those the subdomain level items to try to understand whether we could identify groups of individuals with common sets of vulnerabilities across all of those 16 domains. And we did that using a latent class analysis of that subdomain data in the entire population of the New South Wales Child Development Study. When we did that, these are the 4 early childhood developmental risk profiles that emerged. You can see along the bottom of this graph are all of the subdomain items that were used in the latent class analysis, and the y-axis represents the probability of being vulnerable on that particular subdomain. So with that in mind, I'm just going to run you through the emergence of these 4 classes that were identified. So you can see a class along the bottom in black that are showing virtually no vulnerability on any of those subdomains of the AEDC. And thankfully, they represent 77% of the population, so the majority of children are doing just fine at school entry. And they will be used as a reference group when looking at the characteristics of these other 3 classes that show various types of risk. So in green, you can see a group that are showing mild generalised risk across all of the AED subdomains, and that group accounted for around 11.5% of the population. There's a group there that you can see in blue, and they have particular vulnerabilities on social emotional skills, the responsibility and respect, aggressive and antisocial and anxious behaviour and hyperactive behaviour. So that class of children were named by us to be a misconduct risk group. They are clearly at risk of some social and behavioural problems in later life, and I'll tell you more about that in a minute. And then finally, there's a group there in red, being the pervasive risk class. That group accounts for around 4% of the population and clearly shows a widespread vulnerability across all of the AEDC domains. And so we've done some work with these risk classes to try to understand the utility of them. What can you learn when you group children like this at school entry? And the first thing we did was to try to understand what puts a child at risk of being in one of these risk groups. And when we put a whole bunch of things into a model that you can see listed down the y-axis of this graph, the bottom x-axis is showing you the odds ratio, so the odds associated with each of those risk factors for being classed in one of these 3 risk groups relative to the no risk class. You can see along the at the bottom of this graph that there are a number of perinatal risk factors that have very small but significant effects here that are more likely to occur in children who are in that pervasive risk group and sometimes the mild generalised risk group. You can see at the very top of this graph that being a male child was one of the strongest factors for being represented in the misconduct risk group there, you can see in blue, and the pervasive risk group. But second in line here, as you can see, with odds of over 2 most of the time, is the child having been reported to Child Protection Services prior to school entry. And back then, when we had this first wave of linkage data, we actually only had substantiated reports and out-of-home care placements from DCJ. So we weren't provided in the first instance with non-substantiated reports or reports that didn't reach the ROSH threshold. So these data are showing that children who have a substantiated report or an out-of-home care placement are very highly likely to be classed in one of these risk profiles when they start school. Now, what is the utility of that? Well, all of these risk classes are showing greater likelihood of further problems in later life. And I haven't gone into the detail about each of the papers associated with these findings, but there's a paper for each outcome represented in bold in this slide. So we've been able to show in one paper that there is a higher likelihood of mental disorders among children who are in the pervasive or misconduct risk group. So by the time they're aged 13, these children are appearing in health records with mental disorder diagnoses. They are also showing higher rates of contact with the police by the time they're 13 years old. The other related factor to these particular risk groups identified at age 5 are that the children in the pervasive and mild generalised risk groups are showing poorer academic achievement in later childhood relative to that no risk group. And that's with this when we look at the NAPLAN assessment findings for those children. And so the utility again for identifying these kids at an early age is that perhaps we can assist in the future allocation of resources for these vulnerable children. And here in this analyses that's just been published in Early Intervention in Psychiatry, we've mapped the location of children across the state, basically mapping the regional percentage of children in each of the LGA areas. to highlight those regions who have a higher percentage of children that are showing that misconduct and pervasive risk profile when they start school. So they're the types of things that the study is aiming to do. And with that, all of that data was to do with wave 1. I'm going to move now to talk to you about the wave 2 linkage data, as I was supposed to do in this presentation. So moving to wave 2 linked data, this is now capturing children who have reached the beginnings of adolescence. They're aged 13 or 14. And this graph is simply showing you the number of children that were represented in the child protection data set for this wave, where in this case, we did receive data for all levels of child protection response through from the non-ROSH reports to out-of-home care placements. And now I found it quite alarming that 24% of our cohort had had contact with child protection services by age 13 years. That's, you know, nearly a quarter of the population that is being handled by child protection. And one of the lessons I learned very early on in discussions with FACSIAR staff was that these children are the red flags that other services and other agencies can help with. So 24% of children cannot be the entire responsibility of DCJ, even though that is who you are dealing with. We chose to place the children into a hierarchy of child protection response for future analyses. And so if a child had ever been placed in out-of-home care, we lumped them in the group of out-of-home care placement children. That's the highest level of service they've received from DCJ. And you can see that 2.4% of the cohort had at least one out-of-home care placement before age 13. Then there's a group whose highest level of service was a substantiated ROSH report, and that's 3.6% of our population, or just over 3,000 children. Then you have quite a large chunk of children who have a non-substantiated ROSH report. It's around 14% of our cohort, or 13,000 children. Now, of course, some of those children have had their ROSH report followed up and absolutely not substantiated, and others just actually haven't had their ROSH report followed up because of resourcing issues. And then there are 3.5% of the population who have had only a non-ROSH report as their highest level of service from DCJ. So with that as our new population that we're dealing with in wave 2, I'm just going to take you through a series of findings now in relation to the mental health problems, the school absences and educational achievement, and actually the resilience of these children known to child protection services. So I'll start with mental disorders. And I'm going to focus on the results of 3 papers that are listed here, and you can find them on our website. I'll have a picture of our website at the end of the presentation. There are links to all of our papers there, and if you do have any trouble getting your hands on the paper, just send an email and we can send you through a PDF. Okay, so the first paper was published in 2019, and it was published in the Medical Journal of Australia, and it was a simple analysis to look at the likelihood of a mental health diagnosis in health records between the ages of 6 and 14 years among those children who were known to child protection services prior to age 5 or 6 years, so before starting school. So in our cohort, we limited the data to those children who had parent data because we wanted to control for parental mental illness. So the cohort's restricted to 74,462 children, of whom 18.5% have had a child protection report before school, and just over 4% have got a mental disorder diagnosis in one of our health records. What we can see, and thanks to the FACSIAR team, because I've obviously taken some of the infographics here out of the evidence to action note that goes with this paper, because it just simplifies things beautifully to be able to explain to you. And so what we can see is, of all of the children in the study, there was 9.8% of the children known to child protection services who had a record of a mental disorder in childhood, versus only 2.9% of the children who did not have a child protection contact yet had a mental disorder diagnosis in that same time period. What we could see in particular when we looked at the diagnostic specification of those health contacts is that a child known to Child Protection Services by the time they reached school was more than 4 times as likely to engage in self-harm or be diagnosed with a hyperkinetic or conduct disorder, hyperkinetic disorder being something like ADHD. We also saw that they were more than 3 times as likely to be diagnosed with an emotional disorder or a stress reaction, and more than twice as likely to be diagnosed with a developmental disorder. Now, that's obviously not to say that the child protection notification or contact is causing the mental illness. That is exactly not what we want to say here, but what we're trying to highlight is the child protection system as a red flag for finding kids who are at risk of developing mental disorders, likely because of the trauma that they've experienced in their early life and other familial risk factors that you'll hear about along the way with the rest of this presentation. So I'm just going to show you quickly a couple of graphs that highlight the difference between the groups of children with the different levels of child protection contact. And so when we looked at the likelihood of having any mental illness in that period of the age between 6 and 13 years, you can see clearly here that it's the children that have had an out-of-home care placement that are at much higher odds of being diagnosed with a mental disorder than the other children with a substantiated ROSH as their highest level of service, or the unsubstantiated ROSH. These are an unadjusted model, so there's no other factors involved in the prediction of the mental health problem in this model. So these are very high odds that you can see. And I'm going to take you one step further and show you the same graph, which is for the odds of the particular mental disorder diagnoses. And this time we are controlling for other things like the child's sex, their parents' mental illness, socioeconomic disadvantage or perinatal complications, and yet still you can see these extremely high odds of children that are in out-of-home care at least once in that period of time, but up to the age 6, who have been diagnosed with conduct disorders, hyperkinetic, stress reactions and emotional disorders. And so once again, just to stress that the diagnoses of these disorders is extremely high among this group, but it's absolutely not to say that the DCJ contact's causing the disorders. But it does set us up to ask many more questions about the mental health of children known to Child Protection Services. And one of those questions that we asked, and the next paper I'll show you, is to do with the costs of mental health care among children known to Child Protection Service. So this paper was published in 2020, and it was a collaboration between FACSIAR and an economist that we work with as the first author, and was funded by our NHMRC partnership grant. What we looked at specifically were the costs of both physical and mental health hospitalisations, so using only admitted patient data collection data. And we looked at that over the first 13 years of life. All I'm going to show you today is this graph of the costs per capita of the mental health treatment in hospital for children unknown to Child Protection Services, known to Child Protection Services, and specifically those in out-of-home care. And what you can see in this graph is that the group represented in purple at the bottom as the mental health costs of children unknown to Child Protection Services, and those costs are pretty low across these age bands that are covered here in this graph. The red line represents the children known to Child Protection Services, and just to note, it includes the kids with the out-of-home care placement. It's just any child known to Child Protection Services in any of those years up to age 13. Their costs are starting to rise at school entry, and likely that other peak you can see at age 8 to 9 probably represents an age where the children can start to vocalise their own mental health concerns. Now you can see also very clearly that when you hone in on the group known to Child Protection Services but who have been placed in out-of-home care at least once in this period, the costs are extremely high for that group. And they remain high. There's a bit of fluctuation, but they do remain high. So in essence, this is really just showing you that the costs kick in quite early for this group of children, and they're maintained. But I did want to reiterate that these costs of mental health services are clearly in this limited only to the admitted patient data, and in the prior study I showed you are still limited to what reaches health health data and community service use. So people using private doctors, private psychiatrists are not reflected here. And so this leads me to the last mental health project that I want to talk you through, which was focused on the data that came from the Middle Childhood Survey, where children were given the opportunity to provide their own voice around their own mental health. And just to give you a bit of background about how the MCS was coordinated, we partnered with the Education Department and other independent and Catholic schools to run the MCS in school time, administered by teachers, just like the AEDC, but not teacher rated. The students were taken through an electronic system to complete a questionnaire about their own mental health and wellbeing. And across the state, we had about 35% of eligible schools agree to participate. And we ended up with around 27,000 children who therefore participated in the MCS. I want to thank the schools and children who participated in this, because it was a huge exercise and created some very valuable data. And so I want to show you today a study that is restricted to 26,960 children who completed the Middle Childhood Survey. And that's simply a smaller number because it's the children who had complete data on everything we needed for this analysis. And what we did here was examine the measure that's embedded within the Middle Childhood Survey, within the SDQ, so Strengths and Difficulties Questionnaire. We used the total difficulty score, so the sum of the so-called psychopathology scales, and looked at whether children were scoring in that abnormal level or the borderline level, or were showing normal, typical development in those scales. So of the proportion of children who were scoring in that abnormal level, or they're in the top 10% of the distribution in at least one of the mental health domains within that psychopathology set of scales, what you can see here is that a very high proportion of those children in that top scoring, it's defined as clinically, clinically relevant psychopathology. 48% of those children had been placed in out-of-home care at least once in their lifetime up to age 13. 45% had had a substantiated Roche report. 40% had had an unsubstantiated Roche report, and 36% had a non-Roche report, versus 28% of those children in that top scoring domain had no child protection contact. So I think one of the take-home messages from this particular analysis is that all contact with child protection is a red flag for a child's potential mental distress in middle childhood, and that unless you ask the children about this, you're likely to get a different picture, as we saw in the health data sets for the other analyses. And so the other take-home message is therefore that these sub-threshold signs of mental illness that are occurring at a greater likelihood in children known to child protection services are probably impacting other parts of the child's life. And so that leads me to the next set of analyses that I want to talk to you about, and that's the academic performance and school attendance rates for children known to child protection services. So I'm going to run you through the results of two papers here led by Kristen Lawrence, one of the other senior members of the Child Development Study team. And just to note that there are evidence to action notes related to these papers that you can access via the DCJ website or via our website as well. So the two papers one looks at reading and numeracy attainment using the NAPLAN in grade 3 and 5, and the second paper looks at suspensions in primary school among children in our cohort. So the first paper, reading and numeracy attainment. This paper again is focused on child protection services, but does account for a lot of other factors that contribute to NAPLAN achievement. And this is just to show you that there are two sets of data here, because the analysis for grade 3 uses that as the cutoff point for child protection contacts needed to occur prior to that grade 3 assessment to be able to be analysed as having an impact on that grade 3 assessment, versus when you get to grade 5, we have a higher number of children. 2 more years have passed. There's a higher number of children who have had an out-of-home care placement or a substantiated ROSH or other ROSH or non-ROSH report. So the numbers of children with the child protection contact are slightly different in the 2 sub-cohorts of analyses represented in that paper. And the findings show that if we focus on grade 5, just for the sake of simplicity, you can see that children who had an out-of-home care placement were 3 to 4 times as likely to achieve below that average literacy and attainment standard. And that still, though, children with substantiated and unsubstantiated and non-ROSH reports were all still 2 to 3 times as likely as the kids without those reports to achieve below average on the NAPLAN in grade 5. So without wanting to ignore the rest of the factors that contribute, because clearly this isn't all about these DCJ red flags, as I like to call them. It's not about the DCJ contact. But the other things that were important in impacting childhood education outcomes were these things listed here: socioeconomic disadvantage, pregnancy and birth factors, such as the maternal age at the child's birth, or whether the mother smoked during pregnancy, whether she attended antenatal care. Other parental factors like history of mental illness and criminal offending. The AEDC vulnerability of the child was a very strong predictor of their later literacy and numeracy, which we know from other findings. And so there's a breadth of things that can be addressed in children early in life that could improve their educational outcomes, and particularly so for children who are known to child protection services. Then moving to this second paper that was wanting to help identify students at risk of early suspension so that they could be engaged and effectively supported at school. This study focused on a sub-cohort of our study where 34,855 children were included. And that's simply because those were the kids who had a state government department education record with those suspensions and that were recorded. We do not get that sort of data from the independent or Catholic schools. So again, there was also some data limited to children who had, it was that we were focused on the suspensions only up to the end of the 6th grade. So the risk factor needs to happen before school starts, or before that, before the 2nd grade, and the suspensions are between grade 3 and grade 6. Sorry for that muddled attempt to explain the design. But again, we're just trying to get clear on what came before the suspensions before we try to sort of predict what is involved and contributing to those suspensions. And so what we can see is that compared to children without any child protection contact, those with either the non-ROSH report, the unsubstantiated or substantiated reports, or out of home care were between 2 and 4 times more likely to be suspended from school than children not known to child protection services. Again, it suggests that this isn't just about the kids in out of home care for whom there are pathways set up to try to help with this kind of thing. Other factors that were associated with suspensions from school, again, were things like being a boy. They were more than 5 times as likely to be suspended from school than girls. Being an Aboriginal child meant that you were twice as likely to be suspended from school than non-Aboriginal children. Interestingly, being from a non-English speaking background improved your chances of being suspended. You are half as likely to be suspended, so it was a protective factor. Children showing that aggressive behaviour at school entry, so those items of the AEDC around aggression, they were 2.5 times more likely to be suspended from school. And children from disadvantaged families or low socioeconomic status were twice as likely to be suspended from school. So again, these findings suggest that integrated preventions across agencies are needed to support at-risk students to help them manage their behaviour and fully engage at school. So we are aware that there are school-based programs. These could be supplemented by other support from health and social services agencies. And even though we are aware of the existing out-of-home care education pathway, the findings emerging from this study are suggesting that any level of contact with child protection services could be an indicator that a child would benefit from the programs, just like the out-of-home care pathway. So finally, I'd like to finish on something positive about the children known to child protection services, and that's with a study that we conducted concerned with resilience among these children. That study is published just last year in the Journal of Clinical and Child and Adolescent Psychology. So this study used a subset of data for only about 4,700 children known to child protection services, who also had all of the other data available that we needed to run the analyses required for this study. And what we did was use data from both the AEDC at school entry and a combination of the NAPLAN in grade 5 and our middle childhood survey, which is conducted around age 11, so that we had similar assessment items at that early and middle childhood stage. We used something called latent profile transition analysis to look at transitions across those two time points. And we revealed some groups, and I'm going to run you through how we did this. We basically revealed two groups of children, one showing emergent resilience and one showing stress resistance. And I'm going to show you how we did that and what we found out about those children. So remembering with this one, the entire cohort is known to child protection services because we were wanting to identify a group. They've got to be kind of resilient to something. So they've all had some contact and presumably some level of trauma or adversity in life to have someone make that call to child protection services. So how did we define resilience? So this is going to get messy. I'm going to do my best to explain to you how we did this. We've got time 1 in early childhood, and we've got time 2 at age 11 to 12 years in middle childhood. And we've got the same assessments across those two periods, which are in the middle of this graph: social competence, pro-social or helping behaviour, anxious, aggressive, hyperactivity or inattentive behaviour, and then literacy and numeracy. The top section of this graph shows you the profiles that emerged in the population. So similar to that original study I showed you, we're trying to get classes of kids. Are there groups of kids that show similar profiles across these domains? And when you do this analysis at time 1, you get these 3 profiles: a typically developing profile in green, what we've called an emotionally vulnerable profile, that's in blue. They are particularly showing problems on anxious, pro-social, social competence, other direction, aggressive and hyperactivity. They've got these very, very low scores. They're vulnerable here. And a red group that are cognitively vulnerable, who are doing just fine along all of the social and emotional, but their skills drop at literacy and numeracy. So they're a cognitively vulnerable group. So that's at time 1. You've got to hold that in your mind. At time 2, when you run this analysis again on the same domains, but these kids are now 11 years old, you only get 2 profiles emerging from the population. One that's typically developing and one that's just got a general vulnerability profile across all of the domains, but probably you could say the literacy and numeracy is not too bad in those kids. Okay, so here comes the tricky bit. Early childhood, I've just explained we had 3 different profiles: typically developing, emotionally vulnerable, or cognitively vulnerable. So that's now on the left of the slide. In middle childhood, you only get your 2 profiles to choose from: typically developing or vulnerable. What we did was distinguish the group who are showing that typical developing profile at both time points. And you can see in the green box there, that's around 2,500 children who show a profile of typically developing performance across early and middle childhood. versus a group who were doing well in early childhood. They were also typically developing, but by the time they reached age 11, they're starting to look vulnerable. And that group's about 1,000 kids. And so this first set, you've got a stress-resistant group, and I'm always going to be comparing them to their own control group here, who started off in the same place at age 5, but ended up somewhere else by the time they were 11. Okay, second group, instead of starting off at the typically vulnerable point, now we've got these groups that started off at either emotionally or cognitively vulnerable. In their middle childhood profile, some of them started to look okay. They were typically developing, and that's a group there, again in green, that we've called emergent resilience, because they're starting to show this emerging sign of resilience as they develop. And that's around 639, it is 639 of the children, versus those who showed vulnerable status at time 1 and vulnerable again at time 2. So they're clearly not going to be doing okay, and that's 482 children. So there are two sets, our stress resistance and our emergent resilient groups. The good news, because I hadn't really told you about the percentages, is that it was 65% of the children known to Child Protection Services who were in one of these social, emotional, and cognitively resilient groups. About 54% were the stress-resistant profile, so they were doing just fine across both time points. That's an amazing and very heartening result, that 54% of children known to Child Protection Services are doing fine, on these measures at least. A smaller group, 13%, were the ones showing that emergent resilience, or going from being vulnerable at time 1 to typically developing at time 2. And when we look into the factors associated with being in either of those resilient groups, here's what we see. Both of the profiles, so whether you were stress resistant or emergent resilient, were associated with being female, surprise, surprise, but also with personality characteristics of openness and extroversion. So that's an interesting one. As those personality characteristics develop over time, as a consequence of interactions with other people in the environment. And so, yes, some of it's inherited, but a lot of it's learned. And that's something that I think we need to remember about these measures of so-called personality. The other differences now between the two groups, that some of it's not rocket science. The children who were categorised in the emergent resilience group, they were more likely to have had no substantiated Roche report. That means that they were probably exposed to less severe trauma, and so therefore probably not surprising that if they're exposed to less severe trauma and other things are going relatively okay in life, this child or these children can start to show some emergent resilience as they develop. These children also reported to have a higher level of perceived supports in the community, and that was as opposed to supports at home or at school. So that's an interesting one to note as well. The children who were categorised as stress resistant, in other words, didn't show any signs of vulnerability at any time point. Again, not surprising. These children were from a higher socioeconomic class. They had greater school and home support. They were from more likely from a non-Aboriginal background. Their child protection reports were less likely to even meet the Roche threshold, and they had parents without a criminal history. So there's a good news story there around the percentage of children known to Child Protection Services who are showing typically developing profiles in social and emotional conduct. So I'm going to close up now and just reiterate some of the key findings that I've presented today. Obviously, we've shown that there are these high risk patterns of early childhood vulnerability that are evident when a child starts school. And one of the strongest risk indicators of being in those groups was having a child protection contact before that school entry. So we can get in early to help kids start school in a better place. But apart from those very early contacts, we also have shown that child protection contact is a marker of risk for several things in later childhood, such as mental illness, educational underachievement, interruptions to school attendance. And we've shown that those increased associated mental health costs are evident at a very early age of development. Finally, as I keep reiterating, because it's such a nice finding, that 65% of the children known to Child Protection Services demonstrated a resilient functioning across early and middle childhood, according to those assessments that we used. And so the implications of all of this, which is really important to us that these findings are translated and used, we really want to be able to inform the delivery of cross-agency service provision to these vulnerable families, and doing that from the earliest stage of development. We know that mental health services for children really kick in at age 12 in this country with the Headspace service that becomes available, but there's clearly a need that services need to start much earlier for children known to Child Protection Services and others who are vulnerable for other reasons. We think that school-based mental health programs could aim to promote some of these childhood competencies associated with resilience, particularly the things that are measured as personality styles. And also that if we continue to understand where children are located at particular points in development, we can assist with statewide program planning for particular children at different life stages. And finally, these kinds of analyses and these data are not without limitations. They've got some key strengths, which is obviously that you avoid sampling bias, you don't have people opting in to participate, which often you lose the people you're interested in when you do that. There's also no recall bias for when things happened. It's all recorded beautifully by the different agencies, and we can determine when things happened according to a timeline of development. Also, this method allows us to follow up the cohort into adulthood to determine long-term outcomes after these childhood issues. But the limitations include that the parental data linkage for this cohort is limited to the children who have their birth records registered in New South Wales. We don't have parent records for children who were born in other states and migrated to New South Wales to start school, for example. But also, and probably most importantly, there are really many other potential contributors to health, education and social adversity that can't be gleaned from linked administrative data. And those are things like the quality of someone's relationships at home, or more general measures of the home environment. How many people are living there? Do you have your own bedroom and space? And relationships with carers, for example, when people are placed in out-of-home care. So there's a lot that we can do, but there's also a lot left unanswered that requires other types of research to get in and really conduct interviews and more, nuanced assessments that we can't do with administrative data. So on that note, I'd like to thank you all for your attention and just highlight that this is our website where you can find things like the publication links, the links to evidence to action notes, and other information about our study and our plans for the future. So thank you very much for your attention, and I'll be happy to take any questions.
Fantastic, thank you so much, Melissa. I think if colleagues on the line are like me, there's a heck of a lot of very rich information that you've just taken us through. And I think it's going to take some time to fully chew over and probably a bit of background reading for some of those articles that you've directed us to before we can fully take on board what we've heard today. So can I please ask if people do have questions, pop them in the chat. We've got a few minutes before 1 o'clock to put those questions to Melissa. So I guess, look, I've got a couple to kick off with. I guess keen to understand, has the study, and you touched on it a couple of times, and yeah, I can preempt Kathy Karatas's from SSI's question there, but has it looked at disaggregating the experience of both, I guess, Aboriginal children and children from a cold background, and whether there's specific factors that are relevant for those populations in the findings?
We have attempted to look into the differences in many of these outcomes for children from an Aboriginal and Torres Strait Islander background. One of the challenges with that is that we had convened a reference group to meet regularly with that was comprised of predominantly Aboriginal people. And honestly, it was just, I mean, it's even hard to talk about it. When we would present the findings, it was just everybody kind of slumped and went, oh, how do we report this without reiterating the narrative that the Aboriginal people do not want reiterated? And therefore, a lot of our data on this is stuck in that sort of funnel of trying to work out a way to produce the findings that respects the Aboriginal people and culture. But at the same time, which is what we kept arguing, the truth has got to get out there. There's a lot of assumptions around the numbers. And yes, we understand how, as non-Aboriginal people, I understand how confronting that must be. And as a group, we understand how confronting it must be to look at this kind of data and just go, ugh, more of the same that we don't want to know about. But that's kind of where we're at with that. So we still have a group that we haven't met so regularly during COVID, but we're sitting on some findings that I really can't talk about because they haven't got that approval of that group to be released.
Yeah, no, I can appreciate it. It's a challenging area to do with dignity and respect, I suppose, given some of those challenges. But on the issue of cold children, more specifically, has that
No, we haven't, and that's something we need to do. So I've taken that on board in a couple of meetings. And so, yes, that's something we will attempt to follow up in the third linkage wave.
Look, a couple of questions coming in on the chat. I mean, I guess I just want to make one comment as well. I think it's hard to listen to these findings as well without going, well, what's being done about it? Yeah. And without kind of putting you on the spot for every sort of policy officer across a very broad sector. I do think it's important that that's really for us as the receivers of this information about what we do with it, both from policy and practice perspectives. We know that we've got health and education pathways. To your point, it would be great if they were universal for all children, in child protection or with certain vulnerabilities rather than just out of home care. But I think that is critical. And I know, we did talk about from our own POCLs roundtables, that idea of universal supports rather than waiting for deficits to be appearing and then being assessed and then referred, but actually just assuming, quite frankly, for kids in out of home care, the chances of them not reaching their full potential, regardless of where they rank, is high. So support them with everything we can throw at them, quite frankly. So yeah, I did just want to sort of cover that off because I think it's important. But so look, let me just go to a couple of questions in the chat. Obviously, some interest around parental criminal history and whether that is looking at incarceration or other forms of police or contact.
Yep, I saw that. I can see that question there. Thanks, Virginia. The criminal history, most of the time when I've mentioned it in the presentation and the particular papers, I'm pretty sure it's any type of criminal offence. So what we get is data on criminal offences for anyone who has at least one proven charge, but not every charge we have of information on has been proven. So it's very it's very convoluted, actually, the crime data. The incarcerated people are within that, so we can siphon off and have a look at incarceration alone if we're interested in it. But most of the time we just lump everything together. Is the parent in this database with at least one convicted criminal offence? And if that's a yes, they've got a history of criminality. So we're not counting people who've never had a proven offence, and we're also counting things as trivial as a traffic offence. So that alarms a lot of people, and there are a lot of people represented in those crime databases, and that's why. It's because they're getting some of the very petty things that some of us have had happen, So, yeah.
Appreciate it. Thank you. Question also in the chat from Taylor. I guess curious about, clearly there's some very strong correlation to boys and how they show up in a number of those groups. I guess, has there been any looking at potentially how, that gender bias may be factoring into teachers' ratings, particularly, I think, the comment around ADHD and how that manifests very differently in the behaviours of boys and young girls?
Yeah, I'm not aware of actual research reports about that potential bias, but we've certainly discussed it within our group that the boys are always the ones showing the more overt behaviour that the teacher is going to see, and they're going to disrupt the class, and every teacher is going to know pretty easily which boy is ending up in that misconduct risk profile that I showed you. Yep. Versus the girls who are showing more internalising potentially. They might be and as you've written, I think that ADHD presents differently in girls, and so the girls may just be showing a more introverted, internalising, depressed, anxious, that isn't disrupting the class, so the teacher's not seeing it, and therefore there could well be biases like that on that AEDC assessment because of just how loud and in the face the boys are going to be with their problems versus girls who potentially have also been trained to just take it on and keep it inside in those earlier years. So I think there's a lot going on there that's not just the teacher's fault, it's also, you know, socialisation very early in life and how our boys and girls are kind of taught that they can express themselves.
Question in the chat from Luke. I guess, you know, known fact, kids in out-of-home care kind of grow up surrounded by professionals where their every move is documented to a far greater extent, and how that might impact on the study.
Definitely, and I'm pretty sure we wrote that in the discussion of that mental health paper, where the children in out-of-home care were way more likely to be diagnosed with a mental health issue, but it was probably because they're the ones who had a mandatory health assessment as soon as they were placed in care, and therefore any mental health problem would have been noted at that time. And the other children clearly don't have that level of observation. So definitely that needs to be factored into those findings.
And look, certainly an area of interest for us in DCJ at the moment, and certainly for me personally, I mean, we're looking a lot about the types of child protection notifications we receive, and I guess what concern type notifications, or to what severity we should most concern ourselves with. I guess, you know, listening to your findings, looking at it from the other angle around what experiences of abuse then result in the most prominent impacts in later life. Is that something that we could potentially deduce from this study?
We don't often, I mean, it's there in your data that you provide us, the types of abuse. We've tried a couple of times to make some sense of that, and hit a few issues with just, you know, you don't actually report, you probably report the most severe, and therefore not every type of abuse is captured, even if the child's been subjected to it. So we've often found that when we've attempted to use that data, we find it's fraught with a few caveats that make us just move away from it, so that we're not trying to claim something too strongly that isn't, you know, quite reflective of the truth. But nevertheless, you know, there is, it's valuable data, so it shouldn't be ignored. But that's what's happened so far when we've gone to look at it. We've sort of backed away, going, don't want to make that claim about that particular type of abuse, because in fact it's looking like it doesn't matter what type. It's the level seems to help us a bit more, that level of reporting. Yeah,
I can appreciate that.
Yeah, it's hard.
And the clock's just hit 1 o'clock, so I might bring us to a close. Look, Melissa, obviously I can't thank you enough for what has been an incredibly informative hour. I know I've certainly taken a lot from it, and it sounds like from the chat a lot of people online do. If there's any questions that I haven't got to, apologies. We'll look if we can come back and send around answers to those in the near future. So can I just say one final thank you, obviously to Melissa, to everyone online for joining, taking the time to listen, and I hope you've found this as useful as I have. Yeah, again, thanks for jumping online. Some information will come around also in the chat about our session next month, which is there just popping up on the screen. So we've got a fantastic lunch and learn coming up in May. So again, thanks for joining, and please have a great rest of the day, and we'll talk soon. Thanks again, Melissa.
Thank you very much. Bye.